Thank you everyone so much for joining today. So welcome to the Clinical Trials Methodology course webinar series. As Will said, my name is Courtney. I'm the new project manager for the course, and I'm really glad that you can all join us today. So before we get to the presentation and the Q&A, there are just a few reminders to go over. If you have any questions or comments during the discussion, please feel free to use the chat box or the Q&A features at the bottom of your screen. Also, please complete the evaluation for today's webinar so that we can improve our future webinar series. The link.
Oh, we just lost her.
We just lost you, Courtney.
Yeah, the link, we lost you at the word "the link." Then your audio just sort of like went click.
Can you hear me now? Okay, sorry about that. So I'll post the link in the chat box. And in addition to all of those, in partnership with the AAN, we will be providing one CME for this webinar, and you can indicate your desire for CMEs in the evaluation. Lastly, our next webinar is September 20th, Ethical Issues in Acute and Chronic Neurological Conditions, and this will be presented by Dr. Link. Today's webinar is on adverse event and safety reporting, and it will be presented by Dixie Ecklund and Dr. Fox. So Ms. Ecklund is Director of Operations of the Clinical Trials Statistical and Data Management Center, and Dr. Fox is a neurologist at the Mellon Center for Multiple Sclerosis Treatment and Research, Vice Chair for the Research of the Neurological Institute, Cleveland Clinic, and Professor of Neurology at Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. So I want to thank you both so much for joining us today. We really appreciate your time and presentations. So now we can go ahead and get started.
All right, great. And so what I'm going to start out with, everybody, for those who don't know me, Will Moyer, Professor of Neurology and Emergency Medicine here at the University of Michigan and one of the CTMC course directors. I'm going to go through a few slides about adverse event reporting from a prior webinar that was given by Robert Silverglate back in 2016. And when I'm done with those sort of introductory slides, then we're going to go into a question and answer type session. I'm not going to do justice to the full presentation that was given back in 2016, but I will put a link to it in the chat once I'm done, so that if anybody wants to review Dr. Silverglate doing this. And the idea here is just to give a quick overview of some of the concepts so that we can kind of then dive into some of the finer issues in the panel discussion. All right, so I'm going to share my screen. All right, so you see here is a comic from the New Yorker. You try falling down and scraping your knee, then you can talk to me about pain. And sometimes when we think about developing our adverse event reporting plans, then it's like we can talk about pain, because a lot of things happen in life, and attributing them and annotating them over the course of a clinical trial can be a lot of work. So again, these slides are from Dr. Silverglate. Briefly, some of the objectives are, what's the purpose of annotating adverse events? How do we identify them? How do we review them? How do we code them? And then how do we report them? So the fundamental purpose is that in clinical trials, in particular, randomized clinical trials, you have a unique opportunity to really quantitatively assess the benefits and risks of a treatment. So you want to identify safety concerns, but also exclude safety concerns. Certain types of feelings, experiences, diseases, and diagnoses occur at a baseline level in the population. So being able to determine if your drug or device or behavioral intervention is creating excess adverse experiences is very important for how to contextualize risk. It is important also to account for adverse effects to comply with regulations, both US FDA, NIH, and other countries have similar protections to protect the research participants. So, right, this is the idea of separating the wheat from the chaff, or distinguishing the signal from the noise, and see the dog and the soldier in this picture. So there are different ways of measuring safety when you're doing a clinical trial. One is the primary outcome measure. If it's a survival trial, more people living can be a pretty good signal that perhaps the treatment is safe, although there can be subtleties, of course. Other predefined safety outcomes, and through monitoring of adverse events. If there are serious problems like bone marrow toxicity or something like that, that could be a predefined safety outcome. So these would be adverse events of special interest, practical objective, knowing that there is a biological plausibility behind them, but also communicatable to ultimately patients when they may be considered for a treatment, getting a good sense as to how often there are these untoward effects. So there are a variety of places in regulations and guidelines where things are defined similarly, but not named exactly the same, because if we had everything harmonized, then this just wouldn't be as much fun. But here are a few areas where there is federal regulation in these spots. Here's some places where they don't talk about adverse events, but that are actually pretty important things, like the regulations that govern IRBs, for example. So they don't really describe what this process should be there. Even though it's not unusual for early phase trials for an IRB to be the sort of primary reviewing entity for adverse events. So here are some synonyms. An adverse event could include an effect, an experience, a health consequence, an outcome or occurrence, or perhaps a reaction to a drug or vaccine. I'm just going to skip the quiz because I want to try to get to the Q&A, which I think will be of better utility for all of us. So this is a definition. What is an adverse event? Any untoward medical occurrence in a subject, preferably listing these as syndromes or diagnoses, if absolutely necessary, symptoms, and you report the separate events individually. So one thing that is crucial: what are not adverse events, although they might be part of your adverse event reporting pathway. Death is an outcome. Something led to the death, so there is usually an adverse event associated with death, but death itself is not an adverse event. It comes as the end stage of a diagnosis. Surgery in and of itself isn't an adverse event, but the fact that you had cholecystitis necessitating that surgery is part of the adverse event, and the need for surgery certainly making that a serious adverse event. Pre-existing conditions is something that comes up if somebody has a big stroke, is treated, and then ends up dying of their stroke. We would consider that generally worsening of the condition, since they were at least alive for some period of time. But if somebody had a headache prior to being treated for their stroke and the headache persisted after it, that was a pre-existing condition. So typically that wouldn't be attributed to the treatment that occurred after the beginning of the headache. Abnormal results of tests, if not considered by the investigator to be clinically significant, minor problems with potassium or magnesium, et cetera. Other people's problems and near misses. So things that may be untoward and problematic from a healthcare policy or systems perspective, if they don't have a formal diagnosis and untoward effects towards the patient, they're not necessarily considered adverse events, even though they may be undesirable. Unanticipated problems are something that has a nomenclature that sounds a little bit like this, but these are usually things that tend to have a high likelihood of approximate relationship to your treatment that you really didn't think about happening. Like you have some device and it fails in some extremely novel way. That would be an unanticipated problem. But certain types of adverse events, say bleeding from thrombolytics, are adverse events, but they're not unanticipated because we know with thrombolytic agents, bleeding is a known biologically plausible complication. Some of the properties that you have to think about when you're thinking about how you're going to classify these things and handle them is the seriousness. which is not the same as the severity, the expectedness, and then the relatedness to your intervention. Is it expected because of the disease? Is it expected because of the treatment? Is it related to the treatment, or is it more part of the disease? And a lot of these things require a lot of judgment and thought and thinking in advance. So seriousness is basically how major the problem was with respect to risk of death or major complications like causing or prolonging a hospitalization, and requires some type of intervention to prevent permanent impairment or damage. Expectedness is things that can be anticipated. You've talked about it in the protocol, or if it's a drug in the investigator brochure. So there's notes from animal data and so forth that this could be occurring, and but potentially things that are commonly seen in the clinical course of the disease. Unexpected events are really not anticipated from the intervention or subject's clinical scenario, and again, those need to be accounted for carefully, but particularly in smaller early phase trials, may again not have, maybe mostly noise and not necessarily signal. It is good to have a form of a pre-specified algorithm for relatedness. If something happens 8 weeks after the drug has washed out of somebody's system, it certainly is an adverse event that they had this if they're in your follow-up period, but it's very unlikely to be related. Like, so cholecystitis 8 months after you got TPA for stroke, you can probably go all the way to not related because the timing is wrong. Unlikely, another cause is possible, but not something that the intervention is known to cause. So if TPA causing hair loss, if hair started to fall out after getting TPA, for example, seems unlikely, and there may have been another cause of the hair loss, like a fungal infection of the head. In terms of possibly, this is where often we get into these. Timing is suggested, no other likely causes, and this is something that intervention could have caused. And definitely timing is suggestive, no other possible cause. And this is something the intervention is known to cause. And this is something that's a very important part of the plan, is having this be done in a reproducible way, so that you as the investigator have the plausibility, and your protocol has the plausibility that people would come to similar conclusions on relatedness based on the pre-specified algorithm. So very correlated with seriousness, but it's from the National Cancer Institute Common Terminology Criteria for Adverse Events. I won't go too deep into the weeds here. Again, there's more in that webinar. Treatment resolution and outcome, though, are very important parts of annotating these adverse events. When did it start? When did it get resolved? Were there treatments associated with it? If the patient became nauseated, did they give anti-nausea meds? And again, what was the final outcome? I'm not going to do the quiz. Identifying AEs, over what period will events be collected? When will you look, and where will you look? These are important considerations, particularly if you have a patient who may have a long hospitalization, but you gave a short intervention that will have washed out of their system. Will you be looking for all potential adverse events that are occurring, like minor non-serious ones that are occurring during the hospitalization after sort of brief treatment in the emergency department? Or will you limit your identification to only serious events after some time period, after say the first 4 days of the hospitalization for a short-term treatment? Now, if somebody's on an ongoing med that they're getting recurrently, certainly a different matter, in that you will continue to be monitoring that patient for adverse events as they're on the treatment for longer term. Naming of events, which can be really tricky and important, though, in narrative description. You want to have enough, but not too much. Sometimes templates can be very helpful. And again, we will borrow on the experiences of Dixie and Dr. Fox. And yeah, and me as a PI of a multi-center trial of cardiac arrest of ICU patients, the narratives are quite important because there is a lot going on with these patients. So yes, sometimes this is what we're working. There's a few loose ends for other people to clear up, and then this is the PI and the people at the data coordinating center, the clinical coordinating center, and the site study coordinator work to clear things up after the PI is like, yeah, that was an adverse event. So then what happens with these, depending on the phase of the trial, you want to have some internal review to just do some initial quality checks for administrative errors and completeness and consistency. But you do want there to be some independent review and adjudication when possible. It may not may be handled by the IRB overseeing everything, but you want to definitely have a track, a sort of trackable thing. And for many studies that are more than minimal risk, likely going to need an independent individual with knowledge of the disease and the treatment to do some independent review and adjudication of the events for transparency and to not have the PI have that entire onus on them because they're conflicted because they want their study to work. Coding, again, there's an opportunity to lump versus split. That's sort of a matter of how many things kind of, do you write an adverse event for nausea and another one for vomiting? Or, can you roll those up into nausea and vomiting? Probably it's reasonable in most cases in that example to, call the episode nausea and vomiting. But it's also possible to have a simple nausea episode. There are sort of trees that help sort of phenotype the adverse events. MEDRA is a common one that we use that takes diagnoses and puts them into these sort of phylogenetic trees where you can say, sick to the stomach kind of goes down to feeling queasy. Preferred term is nausea. The high level term, nausea and vomiting symptoms. The higher level term is gastrointestinal signs and symptoms, which may be really what you're summarizing at the end of the trial. And a system or in class of gastrointestinal disorders. So one thing, the people who are doing the coding or the coding computer cannot, sort of interpret 3 events in the way a clinician might say, oh, look, they had polydipsia, high blood sugar, and polyuria. So that means diabetes. Potentially if diabetes was something that the drug caused the patient to have, rolling that all up into this drug caused this person to have diabetes is a very reasonable way of approaching that. And the reporting is going to be to the IRB, to the FDA potentially, depending on if it's under an IND or IDE into the DSMB. The timing matters, reporting schedules vary, but a lot of times for serious adverse events, there's a relatively limited reporting schedule so that the IRB becomes aware of those soon, I guess, particularly if they're unexpected serious adverse events. If there are other sorts of levels of sort of novelty and seriousness, it can sometimes prompt MedWatch reports to the FDA if you're under an IND. And then there's going to be individual reports and aggregate reports. Mostly DSMBs are going to be dealing with things like from aggregate reports. This may get easier in the future in terms of more harmonization, in terms of a more common format, but stay tuned. There are other potential elements of the safety plan, which I think are a little bit too much for us to go into here. And so with that, that's the sort of very rapid overview. With that, before I go into some of my set questions, I do want to let the audience know, please enter in things into the Q&A, and then we'll try to sort of prioritize those questions. And then you can also put them into the chat potentially. And then we will take things from there. So I think before I go into a few of my my sort of planned interview type questions, just wanted to give Dr. Fox and Ms. Ecklund just a chance to give any other reflections on some of the the sort of rapid fire overview I went through with Dr. Silberglide's slides. Like anything I might have triggered or said in a way that was rough.
Yeah, well, thanks for having me here. It's a pleasure to join you all and to share on what can be a somewhat dry topic, but is critically important to accurately and clearly collect safety data around therapeutic interventions. These aren't just drugs, of course. These can be devices. These can be any sort of intervention that qualifies through a clinical trial. And I would say my key take home is that this isn't always clear. And we're used to being in a very perfect world. You send a CBC and you get a number. And you get a number of what the hematocrit is. And you may say, well, the patient was dry, the patient was overhydrated, or whatever, but you still got a number and you have a very clearly defined number. But when you start talking to patients about what symptoms they've had and how their week has been, and there's a lot of fuzziness. And this is an imperfect world. And what we're trying to do is to take a lot of information that patients tell us, and further complicate it, they tell us the information in non-medicalese. We have to translate it into medicalese. We have to translate it into this standardized fashion that we've developed, and to try to get things into different buckets. And I guess it's sort of self-evident takeaway from what you just shared is that it's a fuzzy world out there, and we do the best we can to try to standardize it, routinize it, put them into buckets, get things clarified, and it can be difficult. And so people who are used to the very high precision sort of things, this is a struggle for them. For the psychologists who may be a little bit more familiar with things that are a little here, a little there, it's a little red, it's a little blue, that's a lot more of what this is, yet we still need to try to distill it down to those basic elements. And it's an imprecise way. And so if you think, gosh, I don't think I quite did that right, well, then you're doing it right, because there isn't one right or wrong way to do it usually, and it is a little bit fuzzy and challenging. I'll toss it to Dixie.
I think I'll follow up on that with another issue that comes up is what you would accept in clinical practice is not necessarily what you should be accepting. And when I say accept, and reviewing, reporting for adverse event reporting and research, in any kind of research project that you're working on. So, and it depends on, what field you work in, where your level of comfort is on what's acceptable. The obvious answer is, people that do oncology research, many things happen. All of those drugs cause, bad things to happen. Most of them are expected, your counts are all going to go down. And so, trying to tease out what you expect to happen, what is acceptable, because that's part of the disease progression, and what you're comfortable with as a clinician, because yes, I've seen this many times, this is what we do. And whether that how that plays into the intervention that you might be trying to measure, what the safety profile is. So that's really, I think, where it becomes especially difficult, but it's important that we try to tease that stuff out. Just as over-reporting adverse events is bad, under-reporting adverse events is bad. So trying to strike that balance of, what is reportable. And that's why I think, reviewing this with a few people, depending on the scope of whatever project you're working on, if you're doing your own study on site, talking to a few other people. I always find it amazing. I sit on the IRB at University of Iowa, and investigator initiated studies, year after year, they'll come in and say, nope, we had no adverse events. Nope, we had no adverse events. And it's like, really? But are they reportable? On what level are we reporting them? There's lots of different things that could come in, or there might be another one where it's a paper survey, and they're reporting about the fact that somebody got a paper cut, or all kinds of different things. So working with people who have experience in adverse events reporting at your institution. If you're involved in a multi-center trial, there should be people at the coordinating center level There's often, a safety monitoring committee of some type. And all those things, will get described in a safety management plan to help guide you through those decisions. And probably my only other big point is a lot of times people, we have to report this, the IRB wants to know this. There's a lot of things the IRB doesn't want to know. There are more things that the drug company might want to know because they're developing their investigator brochure. So, it's being transparent about all that information, but coordinators, especially, I think, get very concerned about, we have to report all this. The IRB wants to know this. And at some point, the IRB can't even begin to make any sense out of all that because it needs to be part of the whole drug development process.
No, I think that's a really good point in that a lot of times, and also that gives you both an incentive as an investigator, but just as a scientist to say like, what's the threshold, right? Like, unrelated, non-serious events. How many of those, you want to have a decision tree so that you've thought about whether this is something that needs to be reported. But, at the end of the day, you want somebody to know, why you didn't report the potassium of 3.4, right? Like, it's like, they gave them a banana and nobody did anything about it. They felt fine. It was completely an untoward, there was no untoward effect. It was certainly noise. So yeah, no, those, I think, and I think the other thing, what Dr. Fox was talking about, that sort of also sort of brings sort of the, the heebie-jeebies to a certain degree is, sometimes there are important side effects. So you feel like you have to ask about them, but then you're a little worried, right? Like if I ask people about headache, if I ask the general population about headache, how much of the general population has had a headache in the past month? So you have to have, but if somebody was like, man, I had this headache, it was so bad I had to go to the ER and I got admitted, and it's like, okay, well, that's not what somebody's typical headache is like. That's a sort of different thing. So there is a balance, and then sometimes for acute care studies, you aren't, you don't have necessarily direct access to the patient if they're like intubated. So then you're relying on some inference from the clinical documentation as to what was going on with the patient with respect to the adverse event. So there's a lot of tricks there. So again, for the broader audience, we have really great experienced experts in this. I do have some other set questions that we will sort of move on to as we go. Let's see if I got, oh, look, I got another question here. All right, here's a question. Some multi-center studies have medical monitors review SAEs and designates relatedness with the reports included for the DSMB. A medical monitor doesn't seem to be required by NIH. If you have a DSMB for a multi-center trial, can you have a local investigator provide an assessment to the DSMB of whether the SAE was likely attributable to the study participation, or should you budget for a medical monitor to do this? I'm interested in, I can give a perspective on what we do in the Siren Network, but I'm interested, Dixie and Dr. Fox, if you want to go first on that.
Well, I would first direct people to the NINDS guidelines for monitoring in clinical trials. They've been revised in the last year or two, and they used to be called the Data and Safety Monitoring Guidelines. Now they're called Guidelines for Monitoring in Clinical Trials, but they go through all the steps of what they expect based on what type of trial you're doing. So there's the requirements for monitoring, whether it requires a DSMB. In all of the studies that we work on, if it's a DSMB trial, which is any intervention more than minimal risk, and especially any drug trials, anything placebo controlled, anything with blindedness, all of those things are going to go. But then we also do work with a medical safety monitor who is appointed on behalf of the PI, and they are independent. Often the PI would like to be the medical safety monitor and know about all of those events and provide adjudication on those, but that person needs to be independent from the team. And then for NeuroNext, we actually provide that assessment to the DSMB what the medical safety monitor review has been. We do quarterly reviews with them and then provide them when the DSMB meets. But if it's not a more than minimal risk type trial, it might be that you only have an independent medical monitor who would have oversight, or it could be even, we've had like an observational chart abstraction trial, and then it was just PI and IRB oversight. So there are different levels of that, and they are described very well in the guidelines for monitoring.
So to me, the question might be a little bit orthogonal, or my answer a bit orthogonal, in that the medical monitor, that person's job is usually not primarily to assign relatedness. Now, taking a step back, the relatedness of an AE or an SAE to the therapeutic or to whatever intervention is being evaluated, at least in my experience, is usually done by the site investigator. So usually the site investigator is making that decision. Yes, this is related to the intervention. No, it's not. There then is some additional levels of kind of reality check. Well, does that really make sense or does that not? To me, the medical monitor's main job is to make game time decisions thinking about the patients. Now, the DSMB is the ultimate group that is protecting subjects, but they are not operating in real time. They are always operating after the fact. They see data that's been culled over 3 or 6 months. They meet a couple times a year. They can meet urgently when they need to meet, but it usually takes a couple days for them to meet. They have to have quorum. There's a formal charter for what they do. It's a much more clunky sort of operational structure. The medical monitor is supposed to be the person who advocates for the participants, who is independent so that they are thinking from the perspective of the participants to advocate for the safety of the participants. So they're making game time decisions of, are the inclusion criteria really met or not? Given this new thing with the patient, is it still okay for that patient to continue in the study? So there's a lot of immediate, need to be made today decisions that fall to the medical monitor. And that's mainly what the medical monitor's job is to make those game time decisions when it's a little bit unclear, a little bit uncertain. Now, when everything's straightforward and there's no questions about the inclusion exclusion, there's no SAEs that might cause into question whether the participant should continue or not, then the medical monitor's job is sort of nothing at that point. It's when the questions come up. It's when, because everything takes interpretation. We try to write these protocols as clear as we can, but they never envision every single potential scenario and every nuance of, well, what is serious depression? Well, that's a bit of a judgment call. And how do we decide if that's serious depression? Did their depression get better? Did it get better enough? That's where a medical monitor can come in handy to help with that. Now, in terms of when a medical monitor is needed, again, it depends on the study. So some studies don't need a DSMB. Instead, the DSMP, the Data Safety Monitoring Plan, will outline that a medical monitor is sufficient to protect the subjects over the course of the study, and that medical monitor will then report to the sponsor any potential concerns. And so I've done a couple studies where we really didn't need a DSMB board, but the Data Safety Monitoring Plan just identified the medical monitor, a person who can make some game time decisions, who is independent from the study team, and can give direct input. And usually the way things are is that their decision is binding. The protocol PI can ask questions and can interact, but the idea is not to challenge and to coerce the medical monitor, but to let the medical monitor think about the participants and what is in the best interest of the participants.
No, it's a really good overview. And it's a little bit, but I can see sort of, if you haven't been in kind of the different situations where the study is entirely overseen by the independent medical monitor and they're functioning kind of as a DSMB versus where they are either called an independent medical monitor, but functioning more in that medical safety monitor role Dr. Fox was talking about, to be the, you know, the sort of game time decision on these questions of safety when it is needed, because the the process of the quorum and the impaneling of a DSMB is a longer one, and it's more focused on the aggregate stuff. So yeah, I mean, I would say that in the Siren network, our typical flow has been we've had an internal quality monitor who just helps get the thing into a form that's most interpretable and standard across the sites. That person is not really independent of the PIs of the trial, but it's just helping form it. But yeah, the initial hot read on relatedness and so forth is really the responsibility of the site investigators. And then we look at that, and then after they've gone through the quality reviews, we pass them to the independent monitors or the medical safety monitors to ensure that they concur, because so there is a level of independence and review, but also if there are other patterns that seem to be emerging in the moment, it would take an IRB or the DSMB longer to see that they have that additional level of review. And we have some very independent medical monitors who do sometimes disagree with our attributableness and so forth, which is good, so that there's a tracking system for that, and those things are sort of discussed and annotated. So
Will, we do have a comment from Dr. Robin Conwit from the NIH. She writes, the NIH Safety Monitoring Committee will decide whether or not a specific study requires a medical monitor. So that's an important way of functioning of the NIH sponsored trials. This committee meets after scientific review before council to kind of double check, I guess, and to see, does it make sense what the investigator planned? NINDS often does recommend a medical monitor completely independent from the team and independent from Neuronex, and the medical monitor reviews data in real time. All important points for how the NIH typically implements medical monitors.
And yeah, and since Dr. Conway had raised her hand, I was trying to see if she wanted to say anything else, but I can unraise her hand and assume that we covered it. She'll put more stuff in the chat if she needs to, or if she wants to talk, we can. All right, so the next question I had, and this will be for both of you. This is sort of a question that kind of cuts across research. But if you could travel back in time and talk to yourself when you were starting out in clinical trials, what sort of advice regarding AEs would you tell the younger versions of yourself?
Dixie, would it be don't go into it?
No, I'm trying to figure out how far back in time I should go. I think it's probably the look at the adverse events, and if we're talking about just reporting adverse events on an individual level, but also globally, think about the whole impact of what that is when you report it, and probably give more information than you think you need to. That's probably from my coordinating center perspective. It's like, really, we have one line in here, and it's often then hard to tell, so that for any kind of adjudication of, is it related? Was it expected? What are the events? What were the lab values that you saw around this? Especially when you get into reporting, MedWatch type reporting, if you need to do what you need to do for anything that's related, unexpected, and life-threatening, or results in death. Those requirements are within 7 days and 15 days of notification. So a lot of information needs to be gathered quickly.
Yeah, I would look at it from two different perspectives. One as a site PI and someone collecting the data from the trenches. It would be to try to categorize as best as you can. There is no one who is in a better position to assemble everything but the site PI, who has the direct access to the patient, to the records, to all the details of the things that have gone on. And therefore, to categorize things as best as one can make the decisions or make the call about what things are the best as you can. So for example, you have a patient and you write there's shortness of breath, there's fever, chest x-ray showed an infiltrate, initially thought to be bronchitis, but later seemed to possibly be pneumonia. You know, get off the fence, clean it up. The patient developed pneumonia. You may not be 100% sure, but you make the best judgment, the best call you can, because you have access to the data more than anyone else, more than the data coordinating center, more than the protocol PI. You have the closest access to things. Make the call. And you get to be Monday morning quarterback. So you're often filling these out 4 or 5 days, a week or two when you hear about it after things have evolved. And you are totally allowed to use 20/20 hindsight to say, you know what, that patient developed pneumonia. And here's the story, here's the symptoms, here's the story of what it developed, but this is pneumonia. And so, because remember, someone at the data coordinating center is going to have to bucket these and summarize them and to figure out where these various symptoms and where the different comments from the patients fit into the medical world. For those who prescribe medications, you're used to getting these MedWatch reports from the manufacturer of a patient reported this adverse event. Could you please fill out the make, model, and serial number of the drug that the patient took, which of course we never know. But sometimes it's some vague things like, that drug messed me up. And I'm thinking, no, you started messed up, actually. The drug may have made it worse, but you were kind of messed up to begin with. But, you know, it's these very non-medicalese that are coming from these adverse event reporting. When we're in the clinic, when we're on the wards collecting data for the reporting paperwork, we can do much better than patients and the companies are doing when they're sending us those FDA adverse event reports, because we can pull it together. So I think if I realize that 20/20 is okay, make the best judgment call, that's the most important thing. From the coordinating center point of view, Dixie was alluding to this earlier, be worried about a place with no AEs. Things happen to everyone. They always have stuff that happens. So if there's a site where there's no adverse events and no serious adverse events, usually it's a WNL. We never looked, we never asked. And so, you know, that is suspicious when there is nothing going on and there is no cough, there's no sniffle, there's no flu, there's no upper respiratory infection, there's no bladder infection. The other thing which can be tricky is deciding what is the underlying disease and what is potentially from the therapeutic intervention. And of course, at the end of the day, you never really know. I deal with multiple sclerosis. We have immune modulating therapies, and we have patients who get bladder infections all the time. So when they get a bladder infection, is it from the drug? Because I know the drug modulates the immune system and may increase susceptibility to infections, but I also know my MS patients get bladder infections. So what is it the underlying disease, or is it attributable to therapeutic intervention? That goes along with the expected and unexpected. Was this an expected AE or was this an unexpected AE? And, you know, of course, we're going to be counting up those AEs. So what's attributed and what's not attributed to the treatment ends up often being immaterial. In fact, New England Journal of Medicine doesn't even want you to report whether it was attributable or not. They just want the summary of the AEs and don't bring in your own sort of judgment about what's attributable or not. But we still do collect the attributable or not, and you do the best you can. But I think if it seems like it surprises you, if it's a patient who doesn't have bladder infections and now they have a bladder infection, okay. But if it's a patient who has a bladder infection once or twice a year and she has another bladder infection now, so I kind of use the, well, am I surprised about this, or is this kind of part and parcel with the disease, with the patient, with what I would expect? And that's kind of the best guess. But then sometimes, as we were just talking about, the medical monitor may call up and say, no, I disagree, and you have a conversation and you make the best judgment you can.
Right, but that is also why we do placebo-controlled trials. So you could sort out, you know, there's a certain amount of bladder infection in this population. are there more in the drug treatment trial? So, and that's often why, people talk about whether it's ethical to do placebo-controlled trials, but it's really difficult to accurately describe the profile of the drug or the intervention without a placebo-controlled comparison, or
at least a blinded comparison. At least
Yeah.
a blinded comparison, and then you can just count up the numbers and
Yeah.
see where the numbers lead to.
Yeah, no, and that's also something that in terms of other things where there's interventions or devices, in which case the primary study team is not really blinded, because they can't be. You may have a blinded outcome assessor, but you have to be very cautious that you're systematically you're not overcounting pneumonia when they've got the device, for example. So having some guardrails on what they ought to call pneumonia. I think Dr. Fox's point about pneumonia really resonates, right? Because unlike some conditions where you can have an off-on type definition, pneumonia can sometimes be quite subtle. And I think at the end of the day, erring on the side of reporting, if it's obvious, particularly if it's a pneumonia that's treated, is crucial, important. But in an ICU trial like I'm doing in cardiac arrest, we only sort of annotate and count in terms of our sort of major serious adverse events for pneumonia, pneumonias that meet the CDC criteria for ventilator-associated pneumonia. So we sort of wrote those into the sites. It's like, report this as a serious adverse event. If if they thought they saw a little infiltrate and gave a little doxycycline, but it doesn't meet these criteria for hypoxia or infiltrate, then you can report that as a non-serious AE, because it doesn't meet what we would call the strong sort of ventilator-associated pneumonia. But you have to think of those things in advance. Otherwise, you're sort of scratching your head, looking through them at the end, like, oh, which pneumonias did I really want? So particularly for those things that you can just anticipate are going to happen a lot. All right, so I think my goal in life is usually to try not to run Zoom webinars and stuff right up to the hour, because lots of people have additional things they need to do at the next hour. So I did have one sort of final potential question, but I want to give people the opportunity to type in anything that would be salient, and then I will. If something comes in while I ask the question, I'll just ask the question. So
salient, that puts a lot of pressure on people. Any question you might have.
It doesn't have to be, well, I mean, about adverse event reporting. Like if they ask like about what your favorite immunomodulator for MS is, that would, they'd have to set up a different time to talk to you. I think, I think this is sort of a quick hit question. Like what maybe have you both seen that actually safety independent medical monitors or DSMBs ended up asking for that the PI didn't anticipate? Something where they had to sort of adjust their approach because they sort of missed something, but then the DSMB sort of picked up on something that systematically they were sort of under accounting for.
Yeah,
well in our trials, because we make sure everything's there. However, go ahead, Bob.
Well, I'll share from the Sprint MS trial done through the Neuronext network that one of the things we were measuring were number of new lesions on MRI. And this was in the later stages of multiple sclerosis when we don't expect there to be many new lesions on MRI. And the medical monitor noticed that a lot of patients were having new enlarging T2 lesions on their brain MRIs, much higher than he had thought. And so independent of us, much to his credit, Dr. Stephen Krieger from Mount Sinai in New York, he reported this to the DSMB, and the DSMB convened an unscheduled meeting to review the data. Now, it turned out he identified something that we hadn't quite appreciated, and that is that the new enlarging T2 lesions were coming from a semi-automated software that had a much higher sensitivity to picking up new lesions than the human radiologist. We also had a human radiologist reading the new enlarging T2 lesions, and we looked at that data, and it was much more in alignment with what we would expect. So two things. One is the system worked. The medical monitor saw something that worried him. He notified the DSMB. The DSMB convened an urgent meeting to talk it through. So the system worked. He was worried, and so the things got triggered. The other thing is we realize that there's this disassociation between what the semi-automated software detects on new enlarged and T2 lesions and what the human radiologist detects. And now we're in the midst of writing that up as a paper. So he stumbled upon something or helped us stumble upon something that turns out to be academically interesting and relevant to understanding data coming from clinical trials where the automated software is versus the clinical practice where the human radiologist is. So that was a surprise. And I think it was a demonstration of the system working. He didn't come to me, he went right to the DSMB and we sorted it out. Once the DSMB saw the data, we pulled it, we discussed it, we talked about it, they felt comfortable and the study continued unchanged.
I think the things we've seen added that weren't expected are like better ways to monitor compliance and drug, because that's a really tough thing to do. Better, so they ask for more detailed information to try to ascertain, if there's compliance, drug level, adding drug levels. We've done that in studies where that wasn't anticipated because there would be no way to know of crossovers or what their compliance is, but that still presents a difficulty and it's added cost to the study. So, those things all have to get weighed out depending on how important it is to the question.
Yeah, no, and I do think, even though I sort of glossed over the slide before, thinking about the emergency unblinding procedures, particularly for the placebo-controlled studies, at what point, because then you have to, I mean, we had some acute studies of epilepsy drugs, so there was sometimes what people needed to know and what people wanted to know, and they didn't completely overlap. But it's that becomes a consideration in blinded studies as well. So something that you want to sort of think through, that you don't want the trigger to be so low that you're going to inhibit the maintaining the blind and sort of marching things forward. But what would be the safety circumstances where it is important to know if they're on the active treatment. So, all right, well, I think this was great. I think we covered some unique topics, some of the real sort of kind of inside baseball finer points of adverse event reporting. Again, I know to many of the investigators who are thinking of things the first time, I do agree that your involvement as a site principal investigator is a tremendous opportunity for when you're sort of on the receiving end of this from multiple sites to really take that role seriously and not just kind of hope that the study coordinator is going to kind of figure it all out. Like, having your insight from the medical perspective there is crucial. And we as PIs of multi-center trials, truly appreciate it when the site investigators are there involved and a resource to the study coordinators as they work to try to investigate these things and figure out how best to make those narratives so that you don't get the forward narrative like into Dixie. It's like, patient had status epilepticus, and, their brain, and then, they woke up 4 days later. It's like, okay, there's going to be a few other things that happened in between there that we're going to probably want a little bit more detail on. So, all right. So with that, I did put another link to the evaluation there. But again, I will declare this adjourned unless I forgot anything, Courtney.
No, I don't believe so. Thank you all for coming today.
Yeah, no, it was a real pleasure listening to this, and thank you so much for your time and thoughtfulness.
All right, thanks everyone for joining.
Thank you. Bye.
Have a good afternoon. Bye.